Hi, everyone. We're going to go ahead and get started. Welcome to week 6 of our 10-week licensing lunch and learn. Thank you all for hanging in and being active participants and learning and hopefully feeling a little bit more confident as you prepare to start your study groups and dive into the material with the long-term goal or short-term, because you may be taking it sooner than later, goal of passing your licensing exam. As you know, we shifted to more content overviews for our licensing lunch and learn. So I'm very excited to have Dr. Thompson with us. Are you the newest member of the School of Social Work? Maybe the newest. Maybe, yeah. But a lot of experience, a lot of knowledge and expertise in the field. So as soon as I knew that we were doing a session on assessment and diagnosis, I was like, I gotta ask Dr. Thompson to join us. So I'm gonna look at my cat like jumping on top of my chair. I'm gonna let Dr. Thompson go ahead and start her session and give you a little bit of background and get you all going for today. Thank you again for being here.
Thank you, Shantalia. All right, you guys, so our section is on lunch and learn, the assessment, diagnosis, and treatment planning. I'm Dr. Feezy Thompson. Most of my students way back when I first started teaching said, Dr. D or Dr. Feezy Thompson, is it okay if we call you Dr. D? So if you hear that reference, they're usually talking about me because they don't want to mispronounce my name. So either way, Feezy Thompson or Dr. D is fine. So our agenda for today, we're going to review the exam content. We're going to overview the knowledge, skills, and abilities that is assumed as a part of this section of the exam. And the bulk of this workshop will cover the sample exam questions and sort of the rationale behind the answer. A lot of if you've already gone over some sample exam questions, you'll realize that a lot of them have a little nuance that distinguishes one right answer from the other. So I really want to emphasize paying attention to the question, not so much the answer, but the wording of the question and then the rationale that you have for selecting the appropriate question answer, okay? And then we'll have a discussion after each question. So we have the question, you'll have the opportunity to select what you think is the most appropriate answer, and then we'll discuss right after that question rationale behind the appropriate answer. And then we'll have a wrap up and final discussion for this section of the exam. I have included general references for this section of the exam overall, and then at the end of the PowerPoint are more specific references that you may find helpful in looking at and examining content if it's been a while since you took the courses in assessment, diagnosis, and treatment planning, or if you work with particular theoretical frameworks often and not others, it'll give you some reference books for looking at other theoretical foundations as well. Okay, so let's get started. So the exam content in assessment, diagnosis, and treatment planning part of the exam really focuses on the biopsychosocial history and obtaining collateral data, assessment and diagnoses, and treatment planning. So those are the 3 areas that this part of the exam covers. As you know, this is 30% of the exam, so this is a big chunk of the exam. This is what social workers do primarily. So I want to go through each section and the principles that are covered in each section of the exam. If there are any questions or, as part of the questions on the exam, in the discussion, I'd like you to bring those questions up during that time, specific to the question that we're focusing on in the exam. So the first part of this section of the exam goes over the psychosocial history and collateral data. So as you know, the assessment is a critical piece of a social worker's toolbox. You have to know how to really demonstrate that you can perform a comprehensive biopsychosocial by gathering appropriate history and collateral data when necessary. So the exam goes over the components of the biopsychosocial assessment, It covers techniques and instruments, types of information that's used from other sources in order to gain a great understanding of your client. Talks about methods of obtaining sensitive information, how you can go about that, when it's appropriate to do that. So it does touch upon some ethical issues, the principles of active listening and observation. What does that mean? Indicators of sexual dysfunction, symptoms of neurological and organic disorder. So knowing when it's outside of your scope of practice and when to flip that diagnosis to a different field. So what do those symptoms look like? In addition, the factors and process of assessment and diagnosis, the second part of this section of the exam. As part of assessment and diagnosis, this part of the exam is meant to measure your factors and processes used in problem formation. So most of you have had training in the presenting problem. So what is your rationale? How do you factor in certain information in order to come to the conclusion that this is the presenting problem? And how does that involve your client, for example? How do you gather collateral information? What is that process? So for example, in the emergency room, we don't have to obtain consent. Sometimes it's asked in terms of who is a person with whom we could gather additional information. But because of the nature of the visit, it is a crisis situation, it is an emergency, that is waived and we can contact others to gain collateral information. As you can imagine, a patient who is psychotic is usually not in a position to provide that information. This section of the exam also looks at components and functions of the mental status exam, for example, methods that you incorporate into the assessment in order to come to conclusions. Indicators of psychosocial stress. So if we think about a genogram, for example, the patient being the center, what are those stressors that are impacting this particular situation that brought the client to you at this particular point in time? Okay, we use that in the emergency room. Most clinicians will also use that in a clinical setting. There are certain stressors that present with that client, and understanding that is an important part of this section of the exam. Indicators of traumatic stress and violence, how that also impacts your psychosocial assessment. Methods that you use to assess trauma. Risk assessment methods. This is really important in terms of lethality and suicide risk. What are the methods that you use to gain an understanding of this person's suicide or homicidal risk? Indicators and risk factors of the client's system are also a critical part of this section of the exam. This is a large portion of this section, assessment and diagnosis. And again, I have to go back to the first part. Assessment is critically important before you can get to a diagnosis, right? So gathering information is a critical part. That skill is part of your toolbox and is a major part of a toolbox for a social worker, okay? So the exam really looks at those methods. So when we say methods, what is your rationale for gaining that particular diagnosis? You have a presenting problem, you create a diagnosis. Third part is there's a treatment plan. So all of them are connected, but if you haven't done due diligence and done a great biopsychosocial and gained good information, your treatment plan will be off, your diagnosis will be off, okay? So again, the exam covers methods to assess this client and their system's strength, resources and challenges, okay? Indicators of motivation, how motivated is the patient to change? So again, we have resistance, we have court-ordered clients, we have clients that walk in, we have parents who bring kids in who don't want to be there. What are those indicators, okay? Methods to assess the system's communication skills. And again, directional communication, who makes decisions within the context of a family, those microsystems, the larger community systems that impact a client. and their decision-making ability. Methods to assess the clients and their system's coping abilities. What are some of the coping strategies they currently utilize? Are these negative, or do they actually support the goals that the client has? Indicators of the client's strengths and challenges. And again, this goes back to motivation and how you can assist the client in change. What are their strengths? Their ego strengths as well. The use of the DSM-5 is part of this exam. If you haven't used the DSM-5, I encourage you. I have a little desk copy or pocket copy that I keep with me in the emergency room. Even after 20, 30 years of social work practice, sometimes there are rare diagnoses I'm not sure of. I will consult with a colleague or go back to DSM-5 criteria to make sure that I am on the money in terms of diagnoses and matching my biopsychosocial assessment. Indicators of mental and emotional illness throughout the lifespan. So as you know, a diagnosis for a geriatric patient based on the same criteria that a 15-year-old presents may be very different depending on that life stage, right? So being cognizant of that, that this is representative of a life stage, a developmental stage, that will be measured in this part of your exam, okay? Your knowledge of that. Biopsychosocial responses to illness and disability, okay? Again, paying close attention to the question, okay? When you talk about psychosocial stressors, a patient who's exhibiting depressive symptomology following a terminal diagnosis for breast cancer. It's very different from a person who has experienced major depressive disorder for 16 years and they've been dealing with that, okay? So again, pay attention to the question and the details of the question and the nuances that are in the questions in this section of the exam. It will also put forth questions about psychotropic medications that are prescribed and over-the-counter medications. It will consider that you have some basic knowledge of psychotropic medications and the potential side effects. As you know, tardive dyskinesia is associated with some psychotropic medications and can present in other physically disability physical ways, right? And so being cognizant of that is also important as part of your assessment and diagnosis. Indicators of sleeplessness and feigning illnesses, okay? I think a lot of social workers here have had clients present where there's a stomach ache, there's a headache, there's lots of different symptoms that are associated with a particular activity. In the emergency room, we get lots of people who come in on Sunday night because Monday is what? School and work, right? Excuse me, so this can be indication of feigning illnesses, something that an activity a person does not want to engage in. Basic medical terminology is used throughout this section of the exam as well. And again, I have listed references at the end of the PowerPoint that could help with this if you're not familiar with some of the terminology that could be helpful in the exam. Indicators of behavioral dysfunction, placement options based on the assessed level of care, and perhaps a higher level of care may be needed. For example, a client is in individual therapy. They may need a partial hospitalization or inpatient. Having some basic knowledge of level of care is important in this part of the exam as well. Methods to assess organizational functioning, right? So your relationship to the client and how that can assist the client in this particular assessment. And it's also related to level of care as well. Is this going to be beneficial to the client? And finally, data collection and analysis. Based on the information that you've gathered, what kind of analysis and conclusions did you come to? And again, rationale is critically important in this part of the exam. Next, we want to move on. This is the third part of this section of the exam, and it's treatment planning. So you have completed a comprehensive biopsychosocial. You have concluded that there is a specific diagnosis associated with the presenting problem. And now you are planning to do treatment planning and intervene with this client, okay? So again, like I said, each section of this exam is predicated on a comprehensive biopsychosocial, a proper diagnosis based on rationale, and treatment options that fit that particular diagnosis. Why are you doing what you're doing in terms of the interventions? So this part of the exam looks at methods to involve your client and the client's systems in intervention planning. So is it family therapy? Is it individual? And again, how does that client define family is important. Cultural considerations in the creation of an intervention plan is important. And again, this is, I tell students in the class in terms of, it's usually not a one size fits all, and individualized person-centered planning is critically important, particularly when there are cultural considerations in intervention planning, okay? So this part of the exam tests that, and they will present that nuance in the question as well. The criteria used in the selection of interventions and treatment modalities. Why are you doing what you're doing? Okay. And again, I know a lot of agencies in terms of your accreditation, if they pull charts, they want to see your biopsychosocial assessment. They want to see your diagnosis and treatment plan, and they want to understand your rationale for that diagnosis and the treatment interventions that you're providing to that client. And so there is an emphasis now on cultural considerations and cultural competence. So included in that treatment planning, you may want to include some cultural considerations and or life stage, developmental stage of the client that you're serving. The components of intervention, treatment, and service plans are included in the exam. Theories of trauma-informed care, methods and approaches to trauma-informed care, and finally, the impact of immigration, being a refugee, or undocumented status on service delivery. So sometimes social workers are called upon to do non-traditional therapy. For example, the kids that are unaccompanied minors. Wow, I really messed that up. Unaccompanied minors that are from other countries that are now in border towns. How do you provide social work delivery for those children? And it's typically not, you're in a social work office and the kid comes in. So think in terms of that and how you would provide service delivery to that patient population. So the exam covers that as well. So I went over comprehensively the content of the exam. Now I want to go over some sample questions in the exam content and really talk about the rationale. Any questions thus far? Anyone? All right, okay, quiet group. Okay, so we'll go on to sample questions and exam content. And if you have any questions, like I said, just chime in when we do the discussion portion. Here are some general references that I mentioned earlier that may be helpful to you in approaching the exam. These are very general with the social work dictionary, which includes some of the medical terminology and others. So let's go to our first question. So a social worker working in individual therapy with a depressed client decides to use Aaron Beck's cognitive therapy. Using Beck's cognitive therapy means that the social worker will rely heavily on which of the following techniques to bring about the desired change. Let's select one. So which one do you think it is? All right, everybody got their answer? The answer is B, okay? Beck's cognitive therapy assumes the depressive symptoms can be removed by altering the cognitions that underlie them. Basically, the other answers are not as appropriate, because Beck basically says, in terms of his theoretical framework, that the client has distortions in their interpretation of meanings. And so as a therapist, you're trying to intervene and change that. That's the point of change. You're focusing on removing and reframing their interpretation. So does that make sense to everyone in terms of B being the most appropriate answer? All right. Again, thinking about that question, it's asking specific to a theoretical framework. So again, keeping that in mind. The second question is, during an interview, a client who has HIV disease experiences a referential delusion and displays a flat affect. The client has a history of moderate to heavy substance use and has been using alcohol on a regular basis for several weeks. He's estranged from his family due to his diagnosis. Which should the social worker do first? Select one. Connect the client to a support group to reduce the effects of isolation. Arrange for the client to be stabilized on psychiatric medication. Deal with the alcohol use. Improve poor coping by dealing with social, I can't see my other part of there, stemming from having HIV disease. Everybody got their answer? And the answer is B. And so here, well, font's pretty small, but here you want to basically stabilize the client psychiatrically before you can get to the substance abuse issue. Okay, so it is B is the answer. Okay. Any questions on that before I move on? Why the other answers are not appropriate? Make sense? All right. Next question. A client reports that he has been having difficulties with concentration and decision-making. He feels worthless and has frequent crying spells. He also reports feeling depressed on some days. The social worker asks the client a few questions to find out that he is experiencing, to find out whether he is experiencing any vegetative symptoms associated with depression. Asking the client, I'm sorry. Wait, my PowerPoint just disappeared. Oh no.
We can
can
still
still
see
see
it on
it.
our end, yeah.
You can?
Yeah.
Okay. Wait just
Also,
a minute.
after asking the question, can we just have, someone had asked a little bit more time in answering the question, so give them like maybe 30 seconds or something to put their answer in the chat box.
Okay.
Can you see the chat box?
No, I can't see my PowerPoint right now. Can you guys
Okay.
see the PowerPoint?
Yes, we can see the PowerPoint.
Okay, where did it go? Hold on just a second. There it is. Okay. I clicked something and okay, I'm sorry, you guys. All right. So the chat box is, oh, I see the 5 chats. Okay, got it. Okay, can somebody just raise their hand? Maybe that might help more than the chat box. So
Okay,
you're managing that, Kim, or who's that, Chantalia or Kim that's managing it?
it's Kim. I'm looking at the chat box. So if we want to give them 30 seconds, then I can say, hey, their, answers are in the chat box. And then if you want, I can call them out, whichever ones that people have selected. And, or we can have them just raise their hand and they can come off of mute and answer the question. That might provide for a little bit more interaction.
Exchange. Yeah. So,
Interaction
yes,
exchange. So yeah, we
exactly.
can do it that way. That way it'd be more participation
Okay.
with
Yeah.
the
Yeah.
participants.
So yeah, and in the discussion part, I try to provide a little bit of rationale in terms of why one answer fits better than the other. Okay. So this has to do with vegetative symptoms associated with depression. And asking the client about vegetative symptoms allows the social worker to explore for the presence of which of the following indicators of depression. So again, I'll give you guys some time to select what you feel is the most appropriate.
So Terry Land says C. Does anyone want to raise their hand, or you could just come off of mute and answer the question? And then Dr. D, I don't know if you want them to explain why they chose that answer.
Yep, so D is the most appropriate, okay? And she said C, you said?
Yes.
That's actually the opposite here. So when you think about vegetative symptoms, it's specific to the common signs that are actually identified in D. It's right on the money. When you're asking a patient about depressive symptoms, you want to ask about appetite. Are they eating? Sometimes there's a history of a eating disorder, weight loss, whether they're sleeping, usually associated with insomnia. Energy, how's your energy? That's part of that PHQ assessment in the emergency room. And any changes in their sexual desire, usually we form it in the way of, have you lost interest in things that typically give you joy, okay? Like if a person played tennis 3 to 4 times a week and they say, yeah, I don't play tennis anymore. It's not necessarily a sexual function, but it's something that they really enjoy doing and they're no longer doing it. So that's right, D is right on the money. C is actually the reverse in terms of symptomology that would be exhibited. Okay, does that make sense? All right. Next question. Talking about Erikson's identity formation as the key psychosocial task during adolescence. At age 19 or 20, this task begins to be replaced by which of the following? A, the need to come to terms with one's limitations. B, the need to achieve a higher degree of individuation. C, the need to develop interpersonal closeness and solidarity. The need to be productive and creative. Again, take a look at the question.
All right, does anyone want to raise their hand or put it in the chat box, please?
In terms of what they think is most appropriate.
3 people chose C, 1 person chose B, 4, 5 C, 1 still B. Most everyone is saying C. Does anyone else want to have time to answer, chime in? Okay, looks like we got all the answers that it's going to be.
All right, you people who said C, right on the money, okay? So if you think about Erikson's psychosocial developmental formation, the next stage at 19, 20 years old is beginning and developing intimacy and understanding the bonds of love and friendship. So developing relationships, people are typically thinking about getting married. That's the next stage that Erikson is concerned about, okay? So that's early adulthood. So C is the most appropriate answer. Make sense? All right. So the other answers look at other stages that are not appropriate to a 19 to 20-year-old. And B actually looks at identity and role confusion, which is not part of the Erikson's theoretical framework. All right, moving on. A new client has been referred by a psychiatrist. The client complains of depression. He says that he feels sluggish and unhappy for months and can't sleep well at night. He adds that he's been spending a lot of time alone because he doesn't feel like being around other people. When the social worker questions him, he denies having any suicidal thoughts, though he does say he's feeling tired of being so down. What is the best way to provide treatment in this case? Advise the client to just take medication, arrange for inpatient treatment, offer individual therapy, refer the client to a support group. Which is the best answer here? And again, refer back to the question. Say that again, Kim?
C's, looks like everyone is choosing C for the most part. Yep, C's are coming in.
All right. Okay, for all you C's, you get an A. C is on the money, okay? As you know, individual therapy combined with medication is usually, research shows that this is really good to address mild depression. The client is not at a stage where a referral to a support group would be appropriate because they're less inclined to be interactive because they're depressed and they're withdrawn. They don't want to be around other people, right? And of course, it would be unethical for a social worker to try to get medication. It's outside of your scope of practice, right? So C is the right answer. Okay, correct answer. All right. Next question. Social workers working in individual therapy with a client who has a history of lying and conning people. Nobody has a client like this, right? The client tends to flatter the social worker and ask for special favors such as deferring his fee, extending his session. The social worker feels as though the client is always testing her, and lately she's found it harder to maintain the limits that she set at the beginning of therapy. Last week, the social worker allowed the client an extra 15 minutes at the end of his session because he arrived late. To handle this situation properly, what should the social worker do? A, tell the client how she feels. B, seek consultation with someone who can be objective. C, avoid judging the client. D, refer the client to another colleague.
Like we have A, some Bs. Mostly everyone is choosing A.
Mostly everyone's choosing A.
There's a B, there's a D.
Okay. All over the place on this one, huh?
Yeah. Sort of. B is coming in too.
Okay, all right. So go back to the question. So the social worker has set boundaries for this client, right? And then she herself has gone outside the boundaries, right? B is the correct answer. Okay, so this is a really close question. But the thing is to know when to ask for consultation. If you yourself are engaged in overstepping the boundaries, it's not appropriate to then create boundaries because you're not exercising the boundaries yourself in a therapeutic environment. If you tell the client how you feel, it now becomes your therapeutic session, right? So B would be the best answer to get another colleague's take on what you are doing in your sessions and whether or not you're the most appropriate. So it may come to a point where you do need to flip the case to another colleague, but outside objective input would be helpful at this time. Okay, so B would be the most appropriate answer to that question. All right. Research investigating high, oh, I can't even read my question. Hold on just a second. Okay, here we go. Okay, research investigating high-risk situations associated with relapse for a variety of addictive and other problem behaviors have shown that which of the following account for nearly 3/4 of relapse incidents? A, the urges and temptations of the client. B, negative and positive emotional states and negative physical states. C, social pressure, interpersonal conflicts, and negative physical states. D, negative emotional states, interpersonal conflicts, and social pressure. So again, look at the nuance of the question and the responses available. What do you think it is?
No responses yet. They may be thinking about it. Okay, so D. Looks like D is kind of the consensus.
Okay. All right. So this has to do with strategic coping strategies, rather. And so for a lot of those who have addictions, alcohol and or drugs are a coping strategy. So this has to do with once these psychosocial stressors evolve, what is the most likely thing among the psychosocial stressors to encourage relapse? Okay, that's the essence of this question.
Someone
And
did
then-
choose B and A.
Okay. All right. So B is very close, but D is the most appropriate. Okay. Negative emotional states have been found to be the most frequent cause for returning to the previous coping strategy of addiction. Okay. Marlette and Gordon have good data that supports this, and particularly for alcoholics. 38% of incidents of relapse are related to negative emotional states, 18% to interpersonal conflicts, and 18% to social pressures. So again, if anyone has ever done treatment planning, once a patient has been discharged from a treatment rehab facility for detox, it's always important to look at the return to the environment. Are they returning to the same environment in which they came from? So there's a high incident, high risk factor there when a person is returning to that same environment. So all of the risk factors remain the same that they're returning to. Okay, so that question kind of centers on that. Okay. All right, our next question. A client witnessed a small plane crash a few weeks ago in which the pilot died. Since then, she has been having nightmares, she's lost her appetite, and has felt uninterested in things she usually likes. So again, you've got the depressive symptomology there. Which diagnosis is most suggested for this client? A, acute stress disorder. B, PTSD, post-traumatic stress disorder. C, adjustment disorder with anxiety. D, major depressive disorder with anxiety. Which is the most appropriate?
Looks like everyone is choosing B. Those are coming in fast too.
Ooh, not so fast, not so fast. Go back to the question, you guys, the nuance, the nuance. The nuance in this question is a client witnessed a small plane crash a few weeks ago. So they're presenting to you a few weeks after this has happened,
There's
right?
A, couple people choose A. C's are coming in.
Okay.
So we got A, B, or C.
Okay. All right. So the most appropriate answer is A. And so again, I want you to look at the emphasis is on a few weeks. Post-traumatic stress disorder, there's a time frame for post-traumatic stress disorder. And I believe it's usually more than 4 weeks, more than 4 weeks. Okay. So again, that's the distinction there. A being that this just happened. This is an intervening event. It could resolve itself in a couple of weeks. If it prolongs, it becomes PTSD. If it's an adjustment disorder, there are other manifestations that you don't have that are included in the information in the question. Okay, does that make sense, you guys? Depressive symptomology, and again, I said that, maybe I kind of threw folks off and they went with D. It presents as that which is included in acute stress disorder. It looks like depressive symptomology, but it can be intervening in short term and it ends after the crisis has ended. Some people have different coping strategies and they cope with it, they deal with it, and it subsides or it lessens over time. PTSD indicates that it actually is a prolonged response to this intervening event that happened, and it happens over time, okay? And it continues to present itself as a presenting problem, okay? Make sense, you guys? All right. All right, next question. An 11-month-old baby becomes very upset when his mother leaves the room for a few minutes. This most likely reflects which of the following? A, autism spectrum disorder. B, an insecure or avoidant attachment pattern. C, separation anxiety. D, reactive attachment disorder.
Have some Cs.
Come on, go for it, you guys.
D,
Okay. All right.
it is rather C or B.
Somebody said it's either C or B. Well, guess what? On the exam, you can only choose one. Most appropriate is C. Okay. Separation anxiety. So if you think about developmental stages, at 11 months old, a baby, the primary caregiver typically is mom, right? So when mom leaves the room, that's indicative of separation anxiety. They will whine, they will do different things to indicate that they've been separated from that primary caregiver. So this is actually an appropriate developmental stage response. It doesn't indicate autism, okay? In fact, an autistic child might not even be disturbed that a mother has left the room, okay? It doesn't suggest an avoidant attachment, okay? Because there's no injury or distress. Usually that's indicative of that diagnosis. And a child with reactive attachment disorder is a child who has an avoidant attachment style. So again, this speaks to understanding developmental stages, right? Infant, child, adolescent, older adult, geriatric, okay? So that's important in this part of the exam. All right, make sense, you guys? All right. Our next question. A social worker is assessing a school-aged child who has been acting out in the classroom and defying her parents. She refuses to do her homework or chores. Her parents, who are second-generation immigrants from Korea, work long hours, and the girl's grandmother cares for her every day after school. The social worker is using Bonfenbrenner's, I'm going to call him B, for not being pronounced his name, ecological systems theory to examine the child's development. When evaluating the microsystem, the social worker will study which one of the following? A, cultural values, customs, and laws affecting the girl and her family. B, the connection between the child, her family, and the school. C, the child's immediate environment and face-to-face relationships. D, the parents' work schedules and the family's access to community-based resources. So again, with this one, what is the question asking you? Some of it is fluff that's in here. When evaluating the microsystem, the social worker will study which of the following?
Okay, so we have B. Let me go back here. B, we have a C.
Okay. And this one is really close.
Right, it looks like everyone is done responding.
Okay, most of them are in C?
Now, if someone put A, just put A.
Okay, all right. So think about comprehensively. C is the best answer, okay? Because the systems theory, in particular Bronfenner's, okay, can't pronounce his name, He emphasizes studying a child's development, but also within the context of their immediate environment. So when you look at the answers, like the cultural values and customs, you will gain that from the answer that is C. If you're studying the immediate environment and the face-to-face relationships, you will gain an understanding of the cultural values, the customs, the relationship between the child and her family and the school, and also the work schedules. So C is the most comprehensive that actually encompasses the other answers. Okay, does that make sense, everyone? So this one, like I said, is a little tricky because the answers are actually embedded in the other answers, but C is the most comprehensive that involves all of them. Okay, and that's the information you would actually gain by answering numbers with C as a response. Okay, so again, these are very close in this particular response. Okay, a social worker meets with a family of 4, including the father, the mother, 2 children, ages 18 and 19 for an initial session. This is the first session you're meeting with the client. The mother was recently diagnosed with a serious mental disorder. In the first session, the father and the children focus on talking about the mother's insurance coverage. How should the social worker respond? A, point out and address the family's denial. B, focus on the issue of the mother's coverage. C, reframe the family's behavior as a concern. Or D, ask the mother how she feels about this.
Okay, someone asked why trick questions, and
They said, why trick questions?
trick questions.
These are
And-
actually sample real questions from the exam. So they're not,
Others were answering C.
okay, all right. So they're not trick questions. They provide more of, and I'm not trying to reframe her statement, but they're nuances that allow the social worker to look at things that are distinctions between the answers. And it can sometimes make a difference between one diagnosis versus another. It can make the difference. It can make the difference between one intervention versus another, and also can impact your outcome. So again, that's why I said go back to the question in your exam. I want you to focus on the questions, not so much the answers, because if you really get the question, the answer will come to you.
So some has D. Let's see, B.
Okay.
Do you also explain like how to look at the root of the question? Kind of weed out the fluff part of it. Maybe that would help too. And I don't know if you've already done that. I didn't hear that part.
I did. I said pretty much at the early part of the session that really the rationale of the question. Why are you asking the question? What's the focus of therapy here? So the first part of the question says a social worker meets with a family of 4. So this is family focused. And the mother has been diagnosed with a serious mental disorder. So the social worker is going to be concerned about reframing the family's behavior. Now, the insurance coverage may be part of their concern, but it also may be part of denial about the mother's serious mental disorder. So the appropriate answer actually is C, reframing the behavior, because they're there as a family to focus on the serious mental disorder, right? So again, like I said, rationally, look at the question. It may have more information than you need, but what in essence is the question asking? It's asking, we're here as a family to engage in family therapy to address a serious mental disorder. Now, as part of that, you may segment out mother if needed. Sometimes you do that as an individual to address individual concerns. But asking mother how she feels, she may not want to express that within the context of family therapy, right? Focusing on the issue of the mother's coverage. That's not why the family's there. They're there because of a serious mental disorder. or going on and pointing out and address the family's denial. This is the first session with the family. Okay, that may not be taken as a positive. Okay,
We have one hand up.
Yeah.
Is it
question?
Nokaleta? You can go.
It's Nokalita.
Nokalita, I'm sorry. Go ahead.
No, you're
No,
fine.
Felicia.
Okay, so I was looking at the first thing that came to my mind when they talked about the medical insurance. I would have said followed up on it simply because of the billing concerns. So how do we stop thinking like a social worker? Because if we can't bill the medical insurance, then we can't provide service.
Well, that's true. But again, the focus of this is your first session with the client, okay? You're thinking sort of logistically within the context of your agency. This pulls you into a clinical setting and you are in a therapeutic environment, and they're saying that you have this family here that's there to address the serious mental disorder. Usually you're on a time frame, right? So it may come up as part of, and again, logistically, when a client comes in, I don't know about your agency, but agency I've been previously affiliated with, they run the insurance before you sit in front of that patient, right? So that's already been dealt with before you get to the patient. So that is some of the sort of kind of to deter you from the real question, and that is, what's the focus of this session? The focus of this session is bringing this family together to talk about what? This mother's recent diagnosis with a serious mental disorder.
Okay, I see what
Okay.
you mean.
So it doesn't mean in the absence of after the therapeutic session, you can say, you know, we have someone on staff who can help work through, you know, any concerns you have about insurance. But right now we're here to talk about a recent diagnosis that has been shared with your mom about her serious mental disorder and some of the challenges facing the family, right? So you're reframing that behavior. They're preoccupied, and it may be avoidance. You know, we don't really want to talk about this serious mental disorder. We'd rather talk about insurance or the weather or something different. And by the time you do that, you're 45 minutes or 1 hour, it's over.
Okay, yeah.
Okay.
Yeah, I see your point.
All right. All right.
Okay.
Thank you for the question. All right. I know we're coming up on 122, everyone. And I think, I'm not sure how far I am. This is 33. Let me just check in terms of how many more. I think, yes, about 5 more questions. But I do want to address any questions that you may have in preparation for the exam. Kim and Shantalia have shared with me that they will make the PowerPoint available to you. And again, I encourage you to go through the questions and the rationale behind the answers and really focus on the question at hand. At the end, I have also provided you, excuse me, with resources that I think will be really helpful for you, particularly if there's been a gap between, you know, your education and maybe you're not in, you know, a broad sense, a clinical setting. This provides you with a broad view of theoretical foundations that may be needed, that are needed for this section of the exam. And I think I have about 3 pages, 2 pages of specific to the exam content. That would be helpful to you. So right now I'd like to address questions if there are any.
There was a comment put in that I just kind of want to read in case everyone did not see it by Antoinette. Says a tip that she learned, even though she forgot it for that question, is that if the question is family therapy question, the answer should mirror something geared towards the family. Any other answers that addresses a single person is not family focused.
Oh, good tip, good tip. So back to that question in terms of ask mom how she feels. And again, like I said, sometimes in family therapy, I will pull out one of the individuals who is really having a difficult time engaging with the family. Because again, you're trying to understand directional relationships within the context of the family. And it's okay to do, well, in some contexts, individual. and then re-engage them with the family. So there's some other work that you need to do. So that's a good point, that that's really what you're doing within the context of family therapy. If you're asking mom, so how are you feeling about this diagnosis, right? You're trying to engage individual therapy in a family setting. So good point. I appreciate you for that comment.
Dr.
Anything
Dees,
else?
someone
Yes.
wants you to go to the second page of resources.
Sure. Yeah.
And Sarah, did you have a question about that, or did you just want to review it? Oh, just wanted to see it. Okay.
Okay, so Chantalia and Kim are gonna, so if they have, make sure that both of them, or at least one of them, have your email. This will go out on the email that they have, so that you have it available to you.
There are a few people that I could not identify on our participation list. So if I do say your name, can you please come off of mute and let me know the name that you registered for the program? Antoinette Wilder, I don't see you on my list here. And
Hello.
Brittany Bach and Tomiko.
Hi. Yeah, I just did a direct message with you with my email. So
Direct message with me?
yes, in the
Okay.
chat you should see it.
Oh,
And if not, let me know.
okay.
If not, I can just
And
tell
how
you.
did you get connected with the program?
So me and Tomiko have a Professor Emery, and she gave us the link for this
Okay. All right.
Friday
And so
stuff.
Tomiko, okay, I have your last name, and then let's see, Antoinette. Go ahead.
You had sent me the link. You and I had met like last Friday and you had told me about this. So was there something else I needed to fill out?
No, I was out of town last Friday, so I don't think it was me. Was it one of the other representatives here?
It looks like you on the picture.
It.
We met, we did the interview. It was like last Friday.
No,
The
I was
re-
out of town on Friday. I wasn't at work on Friday, so I'm not
Kim, wrong person. That's me, Chantalia John.
Okay, so it's you, Chantalia. Okay.
Yeah.
All right. So Antoinette, can you put your well, Chantalia, can you just send me her email address?
Yes, I can do that now.
Okay, cool. All right. That's all from my end.
Okay. Any other questions? It's 1:28. We have a couple minutes. All right.
I did have a question. I put it in the chat. Are the answers to the questions on the PowerPoint, will they be provided?
Yes, the PowerPoint in its entirety will be provided. So you have the questions.
With the answers to the questions, so we'll know that we're answering them correct?
Yes. So
Okay,
what's
wonderful.
so the questions are in white, the second page, just like I've gone through this sequence. The second page has the answers in gold. And
Got
then
you.
it provides a rationale for the answers that were not correct. So why that was not correct. And like I said, in most instances, it's one little part of the nuance in the question that changes the answer. Okay.
Thank you very much, Doctor.
All right. All right. Well, it's been a pleasure. Good luck to everyone taking the exam sooner or later. But hopefully these resources will be helpful to you as well.
Are we gonna be able to access the recording as well, or just the slides?
Right now, just the slides, the recordings are being compiled and will be available after the 10-week session.
Okay, awesome. Thank you.
All right. Thanks, Kim and Chantalia, for hosting this valuable workshop. And like I said, good luck to all the participants.
Thank you so
Thank
much.
you, Dr. D.
All right. Take good care.
Okay.
Bye-bye.
All right. Bye-bye.